Okay, I'm Liza Halcomb. I'm from Washington University, and I am reviewing Serotonin Syndrome by Ed Boyer and the late Michael Shannon. Just a little side note, Michael Shannon has a St. Louis connection. His mother, whose name was actually Roger, used to come to the ER occasionally, and both Mike Mullins and I had the pleasure of taking care of her. She was a very nice lady, and when I met her for the first time, I said, "Did you know your son is famous?" And she said, "That's my boy." So we're sad to have him go. So anyway, so serotonin syndrome is a predictable consequence of excess serotonergic tone. It can range from mild to lethal, and it's very important for physicians to recognize the mild or moderate cases because they're very easy to treat. And if they go unrecognized and a physician does add another pro-serotonergic drug, you can have pretty significant and occasionally fatal consequences. The most famous case where this occurred was the case of Libby Zion, which I'm sure you're all aware of. And she had developed severe unrecognized toxicity and resulted in her death. In 2002, there were about 93 deaths reported of serotonin syndrome. Many drugs and combinations are associated with the serotonin syndrome, especially combinations of non-selective, irreversible MAOIs, especially subtype A, and the addition of meperidine, dextromethorphan, SSRIs, or ecstasy. These combinations are associated with severe toxicity, and this is kind of what happened to Libby Zion in particular. There's a clinical triad that is characteristic of the syndrome, including mental status changes, autonomic hyperactivity, and neuromuscular disorders. And you may see a spectrum of these features. So typically, you have to have a history of a serotonergic agent being administered in the past 5 weeks prior to the development of these symptoms. Serotonin syndrome is associated with a very fast onset. In fact, 60% of patients present within 6 hours of developing this syndrome. And they're associated with increased bowel sounds, tremor, hyperreflexia. These patients have spontaneous clonus. Often they go on to develop muscle rigidity, a high temperature greater than 38 degrees Celsius, and they may have ocular or inducible clonus. Later on, they go ahead and develop clonus, agitation, and diaphoresis as the syndrome progresses. You can see all of this in the article in Figure 4 as well, if you can get the article. The clinical features range from mild to severe. In mild cases, patients have tachycardia, mydriasis, shivering. Shivering is one of the sort of big features of the syndrome. And then myoclonus and hyperreflexia. Moderate effects include hypertension, hyperthermia, often greater than 40 degrees Celsius. Patients develop clonus, and what's really interesting about the clonus is it tends to affect the lower extremities more so than the upper extremities. And they get mild agitation, hypervigilance, and a peculiar kind of head turning and neck extension that's a repetitive motion where they kind of look off to the ceiling. It's a fairly characteristic of it. And then in severe cases, they develop a hyperprorexia, shock. They can get agitated delirium, rigidity, and seizures. Laboratory features are usually due to psychomotor agitation and hyperporexia. So they will develop a metabolic acidosis, rhabdomyolysis, transaminitis, DIC, and renal failure. The pathophysiology of serotonin syndrome is really kind of interesting. You can find serotonin receptors that range in the brainstem from the brainstem to all the way down to the medulla. And it's important therefore, in the regulation of wakefulness, thermoregulation, mood, motor tone. And then the peripheral receptors are kind of interesting because they're involved in the maintenance of vascular tone and GI motility. So if you have excess serotonin developing in these areas, you wind up having excess effects in these areas. So you will get agitated because of increased wakefulness, thermoregulation is affected, causing temperature rises. You get GI distress and GI effects because of the GI motility effects, and hypertension and autonomic instability because of the vascular tone. Agonism is thought to be really due at the toxicity is due to excess agonism at the 5-HT2A receptors. They appear to be the most significant receptors involved in the syndrome. However, 5-HT1 and norepinephrine may play a pharmacodynamic role in an interaction role that are involved in the development of the syndrome. So the differential diagnosis is your other hyperthermic toxidromes, specifically anticholinergic toxidromes, malignant hyperthermia, and NMS. There are a few features that are clinically observable that are different between these syndromes and serotonin syndrome. So specifically, in the anticholinergic toxidrome, patients will have dry skin. They won't be diaphoretic. They'll have normal muscle tone. They'll have decreased bowel sounds and urinary retention. So that's pretty easy to differentiate. Malignant hyperthermia is going to be found usually in the setting of inhalational anesthetics, occasionally in the setting of succinylcholine administration. So you have a general idea that it's pretty easy to differentiate between these two. These patients will have skin mottling, rigidity, and importantly, hyporeflexia. But once again, history is going to be most important in these patients. Neuroleptic malignant syndrome is precipitated by dopamine antagonists, and unlike serotonin syndrome, it has a slow onset that develops over 1 to 3 days. These people have normal pupils, they'll be bradyreflexic and bradykinesic, so that can help you tease out the onset of symptoms, can help you tease out the differential. Once again, with your management, you decide if they're what kind of part of the spectrum they're on. And so if they have a hyperreflexia and a mild tremor, you go ahead and give them supportive care and benzodiazepines. You want to withhold the offending agent, and you want to make sure that none of the other drugs that you administer to them can exacerbate the syndrome. In moderate intoxication, you want to give them supportive care and benzodiazepines again. Cyproheptadine is useful. You can give them 12 milligrams by mouth and 2 milligrams as a loading dose, and then 2 milligrams Q2 hours if they remain symptomatic. And then you give a maintenance dose of 8 milligrams Q6 hours. So it really depends on the severity of the illness. And then in the management of severe serotonin syndrome, you want to use direct-acting vasopressors. You don't want to use indirect-acting vasopressors. Benzodiazepines are useful. Non-depolarizing paralytics, and you may want to consider IM chlorpromazine 50 to 100 milligrams because of its anti-serotonergic effects. There are a few pitfalls in the management of these patients. Propranolol has been used in people who have hypertension and tachycardia, and it can precipitate very refractory hypotension in patients who are unstable. Bromocriptine has also been mistakenly used when this has been mistaken for neuroleptic malignant syndrome, and it's actually implicated in serotonin syndrome and can worsen symptoms. So it's actually contraindicated in this intoxication. And dantrolene has had no effect on survival in animals. Once again, people have thought that it's malignant hyperthermia, have administered dantrolene, which may actually cause some muscle relaxant effects, but there's no survival benefit. So that's essentially what this article covered, and I don't know if anybody has any questions. Thank you for your time.